Hello, students. Hi, good evening. How are you all? Hope you all doing good. So today again we are back with a new session. We are going to learn new topic. So welcome to the session. Today we are going to start with congenital heart diseases. So hope you all would have heard of this. So if you would have studied this. So what are these congenital heart diseases? What is this congenital diseases? We'll have in detail explanation in this session. Once we start the session, we'll go through it. So let me introduce this congenital heart diseases first. Congenital, the name itself gives you an idea, which means by birth. So the child will have defects by birth. When they are at the time of birth, they'll have this defects. So especially in this defects, we are only studying heart diseases pertaining to heart. So we are not focusing remaining diseases. In this session, we will focus only the heart diseases. So if you take these cardiac anomalies which are arising as a defect in the structure or in the function of the heart. So either in the structure of the heart, there may be an abnormality, or sometimes even function of the heart may be having abnormality. And these lesions, it may obstruct the blood flow or the blood flow near the vessels. It may alter the circulation. So it will have an impact on the structure. If there is defect in the structure, it will have impact on the functioning of the heart. So either the blood flow may be disturbed or blood flow may be blocked. That is leading to cardiac abnormalities. So if you take, we have different types of congenital heart diseases. Congenital heart diseases is not a single disease. It is not one disease. There are number of cardiac diseases which come under this name congenital heart diseases. They are like acyanotic heart disease and cyanotic heart disease. So acyanotic heart disease, the disease, these type of diseases, acyanotic, the name will give you an understanding. There is no cyanosis. Cyanosis is nothing but bluish discoloration. So there is no manifestation of cyanosis in these conditions. And coming to the other type, there is cyanotic. They are cyanotic means it will manifest in the form of bluish discoloration. So why we are focusing on the cyanosis? Because it is pertaining to your heart. So when the blood is not being circulated properly to the peripheral tissues, when we are unable to supply proper blood, then obviously there will be a disturbance in the circulation that is manifested in the form of cyanosis. So you will have bluish discoloration due to lack of blood supply. That is the reason the classification has been given as acyanotic heart diseases and cyanotic heart diseases. If you take acyanotic heart diseases, we have again left to right shunts and outflow obstruction. So again, there will be category based on the shunting and based on the pathway obstruction where it is. If you take left to right shunts, we have ventricular septal defect, patent ductus arteriosus, and atrial septal defect. If you take the obstruction, outflow obstruction, we have pulmonary stenosis, aortic stenosis, and coarctation of aorta. All these together will come under acyanotic heart diseases. And if you take the cyanotic heart diseases, we have tetralogy of Fallot, tricuspid atresia, transposition of great vessels, truncus arteriosus, and then Epstein's anomaly, total anomalous pulmonary venous return. So these were few of the cyanotic heart diseases that are congenital. So we look into the major types of acyanotic and cyanotic heart diseases in this session. Coming to the atrial septal defect. Atrial septal defect. So if you see the name itself, it gives you an understanding. Always just look into the terminology when you are studying. Because atrial septal defect. Atrial septum has been having one defect. So what is that defect? There is an abnormal opening between the atria. We know that both the atria are connected by a small septum, and atria and ventricle will also have a small septum. Now here we are focusing on the atrial septum. There is an abnormal opening in the atrial septum which allows oxygenated blood and deoxygenated blood to get mixed. Okay, so because of that, what happens? The blood from the left atrium will get mixed with the deoxygenated blood in the right atrium. So right side of the heart will always pertaining with the deoxygenated blood, whereas left side of the heart will have the oxygenated blood. So right side of the heart, which carries deoxygenated blood, will get mixed with the oxygenated blood which is there in the left heart because there is a opening. Atrium at a minor pressure difference, though atria will have little pressure. So when we study the anatomy and physiology, we know that ventricles are been having higher pressure compared to atria. So though the atria has less amount of pressure, but even that pressure will make the mixing of this blood. Right atrium receives blood from superior vena cava, inferior vena cava, as well from the left atrium. So usually right atrium should receive only from the vena cava. Only superior and inferior vena cava should supply blood. Now here what is happening? Even the left atrium will also give the blood to right atrium. So what happens? There will be increased load. Automatically when blood is coming from another structure, load will be increasing, due to which pressure will also build up, right? So increased pressure will have impact on the circulation. So this occurs about 4 to 10% of cardiac anomalies and most commonly seen in female children. Coming to the types of atrial septal defect, we have mainly three types. So ostium primum, ostium secundum, and then sinus venosus. So these three are the three major types of atrial septal defect. So ostium primum, so which is around 30%. 30% of the ASDs can be seen as ostium primum. What it does, what this means, there is a low position of atrioventricular septal defect, which means the entire septum is quite common, but at the lowest portion of the septum may have a small defect or small opening, that is called ostium primum. What about this ostium secundum? Ostium secundum is the quite common ASD. Around 50 to 70% of the cases, we will be seeing this ostium secundum. What does it mean? Exactly in the middle of the septum. So if you take the septum, middle of the septum will have a hole that is called ostium secundum. Sinus venosus is least common, which is around 10%, the site at the entry of superior vena cava into the right atrium. So where the superior vena cava enters, exactly at that site we can see a small opening that is called sinus venosus. Among all these three, the ostium secundum is the most commonest type. Coming to the clinical manifestations of this atrial septal defect. So what happens? Because there is a mixing of blood. So once the blood is getting mixed, the deoxygenated and oxygenated blood together we call as mixed blood. Okay, this mixed blood is being circulated to your body. What happens when you are getting mixed blood? Less amount of oxygen will be supplied to your tissues. Obviously, the infant gets tired during feeding because feeding requires energy, right? So if they suck continuously, they feel tired. When the child is playing, they feel tired. They cannot get play more. They'll be having shortness of breath, difficulty in breathing. They'll have often fainting or fatigue. They'll have profuse sweating because of increased functioning of the muscles and less supply of the oxygen. And they'll have palpitation and stunned growth. So growth will not be appropriate according to their age. Coming to the diagnosis. So remember, for all the cardiac conditions, congenital cardiac conditions, confirmatory diagnosis will only be given by ECG, echoes, and X-rays. So not with auscultation or physical examination. Physical examinations and auscultation will be an additional point for the nurse or the doctor to understand the undergoing abnormality. So it will give us a clear picture that something is wrong with the client, but it is not a confirmation. Okay. So how we will confirm? By means of imaging studies. So chest X-ray is one of the confirmatory diagnosis where you can see a mild to moderate cardiomegaly with enlarged right atrium. So if you see here, the right atrium is having higher pressure when we are discussing, right? So there is an increased amount of blood that is coming to right atrium. Because of this highest pressure, you can see enlarged right atrium and right ventricle too, because from the right atrium, blood eventually enters into right ventricle. And there will be a prominent pulmonary artery segment. So in the X-ray, you can see even the pulmonary artery will be little prominent when compared with the normal, and increased pulmonary vascular markings. So these were the findings that you can see in the chest X-ray. And ECG will give a right axis deviation and right ventricular strain pattern in the lead V1. And echocardiography will be done to understand the position, sizes, and will have signs of left to right shunt. So this will be done to confirm this atrial septal defect. Coming to the management. So how can we manage this atrial septal defect? 20% of all the septal defect will close spontaneously in the first year of span. So 20% of the cases. If it is mild, so if it is around 3 to 8 or even smaller than, it will close spontaneously by its own. Only thing is we have to give supportive management. Like we have to prevent the infection, prevent the load by giving diuretics, and will be giving antibiotics to support the patient from getting infection. If the size of that if the size of that opening is above 8 then they have to wait for 1 year. So at least in that period, if it is getting closed by its own, it's fine. If it is not been getting closed, then a surgery is required. What they will do, they'll perform a surgery, they'll close by using a patch, and then they'll have the regular circulation, or they can go for the normal circulation. So which is a simple surgery. The outcome of the surgery is also very good with the septal defects. So this is what the surgery that we will do, minimal invasive atrial septal defect repair. So in the image, it is very clear that you can see there is a closure by using a defect. So device will be used to close the defect. So you can see there is an opening in the atria, and there is a mixing of the blood. The oxygenated and deoxygenated blood is getting mixed. So you can see here very clearly. So this blood is getting mixed, and we are using a device here. So we are been closing using this device. So because of this, again, there will not be any further damage to your atria. So this is a surgical repair that we will do if the diameter is above 8 and if it is not getting closed by 1 year. So you have to remember this when you are writing the surgery. So apart from that, usually it will be closed within a year. So that's all with the atrial septal defect. And now we'll move on to the another condition, ventricular septal defect. So what is this ventricular septal defect? Ventricular septal defect is nothing but there is a opening between the ventricular septum. So when the two ventricles are separated by using a septum, there is a opening in that septum. Again, because of which the oxygenated and deoxygenated blood is again getting mixed. So the right side of the heart is having deoxygenated blood and left heart is having oxygenated blood. Again, the ventricle having a septum, so there is mixing of blood happening in this. So usually this is most commonly occurring about 14 to 17% of the babies per year. So ventricular septal defect is common about 14 to 17% a year. So if you see, this is what ventricular septal defect look like. Okay. So you can see there is an opening. It is clearly seen, right? Usually this should be closed completely. So this muscle should close completely, or the septum should close completely. It should not allow this two blooded to get mixed. What is happening here? The left side of the ventricle has been filled with oxygenated blood. The right ventricle is filled with deoxygenated blood. The blue color is indicative of deoxygenation and red color is indicative of oxygenation. So clearly it shows there is a mixing of blood. So what happens when the blood is getting mixed? Again, the mixed blood will go to the circulation because left left ventricle will have high pressure of blood, will enter into the right ventricle. Again, it will go to the pulmonary trunk. You can see there is a purple color because this is mixed blood. What the blood which is there in the trunk is pulmonary trunk is mixed blood. So again, there will be damage that happens to the pulmonary trunk as well as the right ventricle, and even the child will have less amount of oxygen will be carried to their bodily tissues. Coming to types of ventricular septal defect, we have supracrustal, membranous, and muscular type. Supracrustal is just beneath the aortic valve at the ventricular outflow tract, and membranous is the most common type, which originates at the inferior to the crus of supraventricularis, and muscularis is in the mid to the apical interventricular septum. So muscularis is exactly in the middle, and membranous will be a most common type which originates just inferior to the supraventricularis. Coming to the clinical manifestations, so usually the manifestations may vary with no effect to severe manifestations. The child will have shortness of breath, poor growth, and failure to gain weight, bounding pulse or palpitation, frequent respiratory infections. They may have sometimes cyanosis, and sometimes the cyanosis may not be persistent. So there will be a reversal of cyanosis can be seen, because of which repeated episodes of cyanosis, they may have clubbing too. Clubbing is nothing but enlarged nails. So they'll have clubbed nails. You can see a C-shaped nail that is called clubbed nail. So this clubbing of nail occurs because of repeated episodes of cyanosis. And coming to the pathophysiology of ventricular septal defect, you can see again clearly that so there is a left ventricular septum, because of which the blood which is entering into the left ventricle is get mixed with the right ventricular blood. So you will have a doubt, why can't the right ventricular blood enter into the left ventricle? Because the left ventricle is having higher pressure. Always the fluid moves from higher pressure area to the lower pressure area. That is the reason the oxygenated blood is entering into the deoxygenated blood. Mixed blood will pass through the pulmonary trunk, and pulmonary trunk will carry the same blood, will get purified and enter again into the left ventricle, but again the same happens. So because of which what is happening, this blood which supposed to enter into the aorta, which supposed to be supplied to your body, will be reduced. The left ventricular volume is getting reduced, because of which the bodily tissues will not get enough amount of oxygen. So that is the problem that we can see here. Coming to diagnosis, so on auscultation, you can feel the S1 is marked by a murmur sound. When you are listening the heart sound, the S1, the first heart sound is S1, that will be that you can listen with a murmur. And S3 can also be heard at the apex of the heart. So usually we'll be observing S1 and S2, but in case of this VST, you can even see S3 sound. Okay. And apart from that, chest X-ray will give you cardiomegaly and increased pulmonary vascular markings. Coming to the medical management, it will be done by using digoxin and diuretics. Only supportive therapy we will give. And coming to the other aspects of medical management, will have adequate nutrition. So high calorie formula or breastfeed can be given to the children. So sometimes it can be supplemented by using tube feedings. So prophylactic antibiotics will be given to prevent the infection, because they are having a mixing of blood. There may be a chance of pooling of bacteria. Expecting that, will give the antibiotics. Surgical repair will be done by using closed stitches. So interventional cardiac catheterization will be done as a septal occluder. Okay, they'll be closing the septum. So that's all with this ventricular septal defect. So we'll move on to the other topic, that is patent ductus arteriosus. So what is this patent ductus arteriosus? Usually we have a structure called ductus arteriosus. So when the child is growing in mother womb, there will be a connection between pulmonary trunk as well as the aorta. And this connection at the time of growth is quite normal till the baby is there inside the womb. That is quite normal. But once the baby comes out after the delivery, it has to close by its own. If the closure, if that is not getting closed, or if the opening is still present, then we consider it as patent. Patent is nothing but it is still there. So this is called as patent ductus arteriosus. So usually, even the definition is giving the same, failure of the closure of ductus arteriosus. Coming to the incidence, it is most commonly seen in premature children. Prematurity is nothing but before completion of 37 weeks of gestation. So usually the children should born after 37 weeks. Then only they'll have the maturity of all organs. If they are born below that, they will have several complications. One among that is patent ductus arteriosus. So usually seen among the premature children. So what happens even through this PDA? You can see oxygenated blood is going to your aorta and deoxygenated blood is going through your pulmonary trunk. Again, there is a connection, the mixing happens. So the same pathophysiology applies here too. We'll see this. So as blood is pumped with a high pressure through the PTA, the lining of pulmonary artery will become irritated and inflamed. Sometimes the bacteria which is there in the blood can easily infect the injured area. Sometimes it may lead to endocarditis, bacterial endocarditis. You can see the image here. This is the quite normal heart, and this is a PDA heart, patent ductus arteriosus heart. You can see an opening here. An opening is there. Okay. So the bluish color is the pulmonary trunk and the red one is the aorta. You can see a opening. So again here, the high pressure blood from the aorta enters into the pulmonary trunk. So what happens? There is a mixing of blood. So what they are telling, because of this high pressure blood continuously entering into the pulmonary trunk, the pulmonary mucosa can get eroded or sometimes can get damaged. What happens when it is damaged? Again, there will be a chance of bacterial growth, which can lead to bacterial endocarditis. Coming to the clinical manifestations, the child may have shortness of breath, congested breathing, disinterest in feeding. They may not show good interest to take feed, poor weight gain, sweating, and tachycardia. Coming to the medical management, it is believed that indomethacin is a drug of choice which will be given along with in the form of IV as intravenous. So it is believed that it can close that ductus arteriosus. So for this PDA, this is the drug of choice to be given. Apart from that, digoxin and diuretics will be given and adequate nutrition should be maintained. So repair is usually indicated in infants younger than 6 months of age when the defect is large and causing more classical manifestations, when the weight is very poor, when they are not even taking the feed. When the manifestations are severe, then they will go for the surgical manifestations. Transcatheter coil closure is one of the surgery where they will be doing for PDA, and PDA ligation is the another surgery. So PDA ligation, the opening will be closed by using the stitches. Coming to so till now we were discussed regarding acyanotic heart diseases, and now we are moving on to the cyanotic heart diseases. So as I said, cyanotic heart diseases will have a classical manifestation of cyanosis. That is why we are terming it as cyanotic heart diseases. Usually these cyanotic heart diseases, we have more number, right? When we are introducing the topic, I told you, but we are going to see only very few of the cyanotic heart diseases. We'll see tetralogy of Fallot and TGA. So firstly, what is this tetralogy of Fallot? Tetralogy, so tetra is nothing but 4. So in this condition, the child will have 4 different abnormalities. That is the reason we are calling it as tetra. What are those 4? The first one is ventricular septal defect. Second one is pulmonary valve stenosis and overriding of aorta, right ventricular hypertrophy. These 4 are the conditions that together we call as tetralogy of Fallot. Ventricular septal defect, which we have seen already. The septum will have an opening. Ventricular septum will have an opening. Pulmonary wall stenosis. What is this pulmonary valve? Pulmonary valve is nothing but the valve which is present in the pulmonary trunk. So this valve allows the blood to move into the pulmonary trunk. What is happening here? Stenosis of that pulmonary valve. Stenosis is nothing but it is getting close enough. So when it is stenosed, the blood has to move to the pulmonary trunk with higher pressure. It has to go with higher pressure. So which is again adding on factor for your heart to work more. Overriding of iota. Iota will not be there in proper position. So instead of its own position, it will have displacement in its position, and again that will be a leading factor of your heart to work more. And right ventricular hypertrophy. What is happening? Hypertrophy is increased in this size. Your right ventricle is getting increased in its valve. The right ventricular valve is increasing. So if it is getting increased, the pumping capacity of your muscle will get decreased. So when the valve is thin, it will pump easily. When the valve is getting thick, it is very hard for the valve to pump the blood. So that all these together, we call it as tetralogy of Fallot. So you can see this, the image will give you a better understanding. So you can see pulmonary stenosis here. So this is a stenosed. So if you see in the left side picture, it is very clear that pulmonary valves are very patent. They allow the blood. Here in this, you can see it is completely closed. So it is not even allowing blood to enter into it. And then next is ventricular septal defect. As usual, the ventricle is having an opening. A right ventricular hypertrophy, you can compare both the images. So this is normal heart where your right ventricle is quite common. The wall is very thin. On this side, you can see a very thick wall. If the wall is very thick, the heart cannot pump properly. Overriding of iota. So you can see the position of iota has been changing. So all these together making your heart to function very hard. So coming to the pathophysiology, what is actually happening due to the pulmonary stenosis? A right ventricle has to work more harder to push the blood into the pulmonary trunk, whereby increasing the right ventricular pressure and size. So when the right ventricle is functioning harder and harder over a period of time, what happens? It is functioning hard, and because of its harder function, the muscle gets thickened. That is called right ventricular hypertrophy. Why this is happening? Because there is a pulmonary stenosis. Pulmonary stenosis is making your right ventricle to work hard, and that is giving right ventricular hypertrophy. Presence of ventricular septal defect facilitating the blood to pass from the right ventricle into the left ventricle, and again there will be a higher pressure, right? Already the right ventricle is having higher pressure because of the pulmonary stenosis. Again there is a add-on pressure because of the VSD. Ventricular septal defect is giving more pressure. The blood is passing again through this opening. So more and more pressure is there in the right ventricle, so that the hypertrophy of right ventricle can be seen. What happens with the overriding of iota? Iota will sit above the both ventricles over the VSD rather than just over the left ventricle. So actually it has to pass just above the left ventricle. Instead of that, what is doing? It is passing over both the ventricles. What is happening as a result? Oxygen poor blood or the deoxygenated blood from the right ventricle can directly flow into the aorta instead of pulmonary trunk. Actually, it has to go to the pulmonary trunk, but aorta has been displaced. So because of that, it will enter into the aorta. So decreased pulmonary blood flow will be seen. Poorly oxygenated blood will be circulated to the body. When the pulmonary blood flow is decreasing, you will not get oxygenated blood properly. Again, if you are receiving oxygenated blood also, there is a septal defect. So again, mixed blood will be supplied to the baby. So baby will not get oxygenated blood at all. So because of all these defects, so what happens eventually? The baby will manifest with cyanosis. Cyanosis is the classical manifestation of this TOF. So bluish discoloration of skin, lips and nails and nail buds will occur when they are crying, when they are feeding, when they are irritable, when they have fever, when they when they show any bodily movement, when they have increased body movement. So in all these incidences, you can see cyanosis because body is working. If the body is working, body needs to utilize the oxygen, right? When there is lack of oxygen, it will manifest in the form of cyanosis. Apart from that, they'll be lethargic, they'll have reduced physical activity, and they'll have frequent fainting, clubbing of nails, and they will even have breathing difficulties. We'll have a special manifestation here called TED spells. What are these TED spells? TED spells are nothing but because of this unrepaired tetralogy of palate, the child will present with TED spells. They will have acute hypoxic effects, which is characterized by shortness of breath, cyanosis, agitation, loss of appetite, and sometimes even syncope. Syncope is loss of consciousness. So they will have all these manifestations. All together, we call it as TED spell. So these TED spell may be initiated by how this TED spell can be initiated. It can be initiated by crying or having severe bowel movement or having pain, sometimes dehydration or fever, which can lead to increased oxygen demand in your body. When the oxygen demand has been increasing, your heart needs to work more. Even though your heart is working more, oxygenated blood is not being supplied. So eventually the child will have these TED spells. So here is an image where you can see very clearly how the child will look with the TED spell. You can see there is a bluish discoloration in the oral mucosa. So the fingertips are been turning into blue, even the toe tips are been turning into blue. So this is a classical sign that you can say without doing any diagnosis that the child is having TOF. Coming to the diagnosis, on auscultation, there will be a systolic murmur, so which you can be observed because of, this is because of pulmonary stenosis. Apart from that, it usually requires surgical repair because without surgery you cannot cure this condition because there is not one defect, right? We have four defects which is affecting your heart. We cannot even wait for longer period. Usually the surgery will be done within 6 to 18 months of age. So it involves closure of VSD with the tangential patch and correcting the overriding of aorta as well the pulmonary stenosis. If we correct these three, automatically the ventricular hypertrophy will get corrected because the pressure to the ventricle will get reduced. So obviously that will also get corrected. So that's all with the TOF, tetralogy of palate. And coming to one cyanotic heart disease, that is transposition of great vessels. What is this transposition of great vessels? The aorta is connected to the right ventricle and the pulmonary trunk is connected to the left ventricle. Very difficult and very typical condition, you can say. So aorta must be connected to your left ventricle. Pulmonary trunk must be connected to your right ventricle, right? So here what is happening exactly the different connections you can see. What is happening there because of that oxygen poor blood which is returning from the right atria from the body passes to the right ventricle and from the right ventricle it will eventually go to your aorta. How funny, right? Usually it has to go to the pulmonary trunk, it has to get oxygenated, and then it should go to your body. What is happening here? It will come from your body, from the atria to the ventricle, again to the body. So only the deoxygenated blood is getting circulated. On the other side, only the oxygenated blood is circulating to the lungs, to the heart. Right. So from the left ventricle, it will go to the pulmonary trunk. Again, it will go to the lungs. Again, it will come to the heart. So there is a two different circulations that you can see. It is not one circulation. Single circulation cannot be seen here. So if you see, yeah. So cyanosis is again a classical manifestation of this condition because the two different circulations are arising. The child will have rapid labor breathing and cold and clammy skin, failure to thrive. They will not be able to eat at all. So you see this image, which is very, very clear. So if you see this image, this is a TGA circulation. So we have systemic circulation as well, pulmonary circulation, right? So usually what happens from the right ventricle, it has to go to the pulmonary trunk. and from the left ventricle it has to go to the aorta. Instead of that, it is bifurcating and it is going in different direction. You can see here. So from the vena cava, it will enter into the right atrium and it will enter into the right ventricle and into the aorta. So aorta, again systemic circulation again. On the other hand, you can see the pulmonary artery into the left ventricle and then into the pulmonary vein, again pulmonary circulation. Again the same happens. You can see two different circulations here. There is no mixing of blood at all. I mean to say there is no oxygenation of blood. Whatever the deoxygenated blood is there, it is circulating again as deoxygenated. The oxygenated blood is circulating again as oxygenated. So the body is not even getting the oxygen here. You can imagine the severity of the condition. So how will manage the client? So there is not even mixed blood is supplied to the body. On the other conditions, at least you can expect 2% oxygen will be supplied, but in this condition there is no oxygen at all. So how your body will going to work? So the body cannot be able to manage this condition. Only with the help of ventilator we have to manage the condition. So we have to ventilate the client. We have to do cardiac catheterization. So cardiac catheterization will be done. Balloon atrial septostomy will be done. So all these are surgical procedures which will be helpful to manage this condition. IV prostaglandin will be administered, and by second week of life, TGA repair is done. So only because we cannot extend the period, there is no oxygen supplying to your body. So by second week of the life itself, we will do this surgery. Coming to the nursing management of this condition. So before managing this condition, it has to be informed to the children that there's what is actually happening. So it is not normal and it is quietly abnormal, and the circulation which is going in their body is quite abnormal. They can observe a rapid change in their growth. The child will not attain growth at all. The child cannot even be able to attempt single activity. Even if they cry, if they drink milk, if they do little movement, their body will not support because completely lack of oxygen. So all these must be informed to their parents earlier when you're taking the client, and you have to inform the manifestations like cyanosis and chest deformities, retarded growth, inability to take feed, lethargic, irritability. All this you have to explain before even going for the surgery, because around second week only we'll take the child for the surgery. Till the time the child will be managed only on the ventilator. In order to reduce the parental anxiety, in order to reduce their tensions, it has to be informed earlier regarding the child. And so you have to assess the chest deformities. You have to assess for any respiratory pattern and any other form of complaints that the child is having, that has to be assessed. Clubbing of nails or disturbance in their breathing patterns. All the things must be noted. So that's all with this today's topic. So till now we have been discussed regarding congenital heart diseases. So what were these congenital heart diseases? So we have different types of congenital heart diseases: acyanotic heart diseases and cyanotic heart diseases. So acyanotic heart diseases, we have seen what is atrial septal defect and ventricular septal defect and patent ductus arteriosus. And coming to cyanotic heart diseases, we have seen tetralogy of Fallot and transposition of great vessels. So why we are focusing only this? They are very important when compared to other types of disorders. So if you have any doubts, so you just go through Prakara. Prakara will give you a better understanding of the subject. So you can learn the subject in a better way. Please subscribe to Prakara, and you are free to search in the YouTube. So you have n number of teachers, those who are teaching, and you have different subjects. All the nursing subjects are being taught. So just go through once and have a better learning, and learning can be made easy with this Prakara. Thank you.